Hello everyone, and welcome to today's webinar titled Implementation of Molecular Diagnostics for SARS CoV-2. This webinar is part of the ongoing coronavirus virtual webinar series presented by LabRoots. I am Kaylee Bach of LabRoots, and I will be your moderator for today's event. Now let's get started. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you'd like during the presentation. To do so, simply type them into the Ask Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, click on the Ask a Question box located on the far left of your screen. As a reminder, this presentation is educational and offers free continuing education credits. Click on the Continuing Education Credits tab located in the top right corner of the presentation window and follow the process to obtain your credits. I now present today's speaker, Dr. Jiang, Sichuan Academy of Medical Sciences, Sichuan Provincial People's Hospital, Sichuan Provincial Center for Clinical Laboratories. Dr. Jiang, you may now begin your presentation.
Hello, everyone. I'm Jiang from Sichuan Provincial People's Hospital in China. I'm very glad sharing our experiences and study of molecular diagnostics for SARS CoV-2 during this pandemic. First, let me introduce our hospital, Sichuan Provincial People's Hospital. It is one of the largest government hospitals in Sichuan province, established in 1941. To date, our hospital has more than 4,000 beds and near 7,000 employees. We serve more than 4 million outpatients and 120,000 inpatients per year. Okay, as we know, by the end of this March, a pandemic of COVID-19 caused more than 750,000 confirmed cases of COVID-19 and 36,000 deaths around the world. We are facing very serious situation because of the virus. So today I will share how we established nuclear assay testing for SARS-CoV-2 in our lab. Then I will talk about our study to answer the question related to diagnostic efficiency of nuclear assay testing. Let's go through the events occurred at the very beginning of the pandemic, which are related to molecular diagnostic testing for SARS-CoV-2. The outbreak was first reported at the end of 2019. By January 7th, SARS-CoV-2 virus was identified by Chinese scientists. Five days later, Chinese CDC released the virus genomic sequence, which made clinical labs and manufacturers possible to develop nuclear assay testing for virus. On January 16th, the first batch of commercial RT-PCR test kits were distributed to Wuhan, and 3 days later to other provinces across country, including our Sichuan province. Actually, our lab started running the test on January 20th. In the first period of the outbreak, all tests were completed by China CDC and public health labs. Over time, the testing volume rapidly increased, and the National Health Commission decided to allow all local qualified labs to perform the testing, including hospital clinical labs and independent labs. At the same time, Chinese FDA provided emergency use authorization to IVD manufacturer. On January 26, first 3 RT-PCR kits were certified by CFDA. On January 29th, our lab was appointed as a reference lab for SARS CoV-2 by Sichuan Provincial Health Commission. Actually, from identification of the virus to first 3 nuclear assay testing certified spent less than 20 days. It was remarkably successful in molecular diagnostics of infectious disease. So our lab established this assay in 3 steps. Fortunately, when we decided to run nucleic acid tests for the virus, there were few commercial RT-PCR test kits available. Thus, we selected 2 kits based on targeting genes, internal controls, limited of detection levels, and RNA extraction methods. After quick validation with quality controls and around 100 clinic specimens with 2 test kits parallel, we eventually established the assay in 1 day, which had the 3 target genes, self-skipping genes as internal control, and 200 copy per ml for limited of detection level and automated RNA extraction method. Then we built a routine workflows of the test for our lab. The whole process could finish in 4 to 5 hours, but including specimen transport and waiting for enough specimen to run together, real turnaround time usually varied from 5 to 8 hours in our lab. As we know the virus not much, especially in the very early period, we took biosafety level 2 for lab and biosafety level 3 for lab personnel who handle primary respiratory specimens. We also upgraded RNA extraction space to lactic pressure room. Then later, we did 556 degree for 4 minutes treatment for all respiratory specimens to inactive the virus. There is an infection to the results. Actually, we did not find, but there are some lab reported. So we highly recommend that you test it in your lab before you use this inactivation step. To protect our open space central lab from contamination by COVID-19 patient samples, we set up a SARS CoV-2 stat lab in a separate room to run regular tests for COVID-19 patients. Lab technicians working in this lab have to take biosafety level 3. The lab runs 24 hours a day and 7 days a week. So to ensure test quality and biosafety, we trained lab personnel in our lab and also in more than 300 labs in Sichuan province online. Anyway, our lab is also Sichuan Provincial Center for Clinical Labs, responsible for providing EQA and guide lab quality control. Through these 3 steps, we established the nucleic acid test in our lab. Our molecular biology lab could run 300 tests every day, and we serve 24 hours for clinic every day. So who should be tested for SARS CoV-2 in China? Our national clinical guidelines of COVID-19 strictly defined 2 groups of people. First group is suspect cases who have epidemic history and clinical symptoms and signs. The second group is persons who have epidemic history but no COVID-19 symptoms. So to identify the asymptomatic cases could facilitate early diagnosis, early quarantine, and early management, then to prevent the virus transmission further. So the nucleic acid testing has played a significant role in this pandemic. However, a few concerns about its detection efficiency have raised since early clinical implementation. In my second part, I will share our large cohort study, then hope to answer the questions related to diagnostic efficiency of nucleic acid testing. So the questions need to be answered are which types of specimens are optimal for the nucleic acid testing? And when is the optimal time of specimen collection for initial diagnosis of COVID-19? Then how many specimens should be consecutively collected to improve initial diagnostic efficiency? Are there any more reliable methods available for early diagnosis of COVID-19 besides nucleic acid testing? So we are going to answer this question based on studying COVID-19 patients in Sichuan province. Sichuan is a province located at southwest of China. Total population is about 80 million. As for March 9th, there were 539 lab-confirmed patients. So our investigation included 532 patients with full recording. The majority of patients was moderate cases. They are 75.2%, and the rest include the mild, severe, and critical cases were 9.2%, 9.6%, and 6%. The severe and the critical cases together were 15.2%. And there were 4,275 nucleic acid test results from the 532 patients included in the study. The top three sample types are 46.7% throat swab, 23.4% sputum, and 13.4% feces. Nasopharyngeal swabs were only 7.4%. Nasal swabs were 5.9%. And very few specimens include 2% blood and 0.4% BAF. So the result for these two are not very accurate, actually. So out of the 4,275 test results, there were 1,605 were positive. The positive rate was 37.5%, which is consistent with previous reported data. So since such low the positive rates actually has been criticized a lot. So to find out which specimen types have higher detection efficiency, we compared the positive rates among 7 specimen types. BAF, nasopharyngeal swabs, and sputum were top 3. Their positive rates were 77.8%, 40.4%, and 39.8%. Throat swabs and nasal swabs followed were 38.5% and 35.9% positive, so ranking 4th and 5th. The positive rate of feces is 34.1%. Blood was only 5% positive. So we compared 3 upper respiratory tract specimens. There were no difference. But actually, upper respiratory tract specimens was significantly lower than that of sputum, but significantly higher than that of the feces. So, according to our results, and considered both detection efficiency and convenience, sputum and upper respiratory tract specimens should be used for nucleic acid testing. So then, to elucidate SARS-CoV-2 positive rates at different disease stages, we draw daily positive rates of upper respiratory tract specimens, sputum, feces, and overall specimens between 5 days before and 40 days after symptom onset. The SARS-CoV-2 nucleic acid test positive rate for overall specimens showed as the empty bar. The presented as a U-shape across the disease course, with the first peak around 85% to 95% from 3 days before to 3 days after symptom onset. The bottom is around 20% at 50 to 20 days after symptom onset. And the second peak was around 35% at 35 days after symptom onset. And both upper respiratory tract specimens and sputum had the similar pattern of the positive rate trend as overall specimen across the disease causes. But the positive rates of sputum always higher than the upper respiratory tract specimens, as shown in this figure. Feces swab showed continued decrease from the symptom onset to the end of the disease course. Actually, there's paper reported at the same trend and suggest the feces may, the virus loading in feces may be represented the disease progress very closely. So the optimal time of specimen collection should be as close to symptom onset as possible. So repeat sampling is needed to increase detection probability, especially when the patient comes not within the 3 days before and 2 to 3 days after symptom onset. So to elucidate the optimal numbers and types of specimen collection for effective initial confirmation of the COVID-19 patients, we calculate the accumulative positive rate of consecutive sample from the COVID-19 patients. For the most frequently collected upper respiratory tract specimen, 75% of patients had a positive result after one swab collection. So 81.7% patients had a positive result after 2 consecutive swabs, and 85.2% patients had a positive result after 3 consecutive swabs. But even until 7 consecutive swabs, the positive result rate cannot reach 90%. So we include sputum for the testing. We can see the cumulative positive rates increased rapidly from 83.7 for first swab, rapidly increased to 90.2% after 2 swabs and 2 samples, and 94% after 3 samples. So take these results, we can suggest mainly combination of minimum 1 sputum with 1 upper respiratory tract specimen will be better than used upper respiratory tract specimen alone, the better. So to find whether antibody tests could be an alternative assay for early diagnosis of COVID-19, we recruit 74 patients and consecutively tested their IgM and IgG with immunoassay within 1 month after symptom onset. As shown this figure, antibody levels of both IgM and IgG increase as time. However, the positive rates of both antibodies in the first week were only around 40%, increased to about 75% in the second week, and reached 90% until the third week. So, based on this result, to date, nucleic acid testing is the best test for early diagnosis of COVID-19, and antibody testing could be supplementary. Of course, we are looking forward for the antigen testing come out soon. So taken together, to improve early diagnostic efficiency of nucleic acid testing for COVID-19, combination of minimum 1 sputum with upper respiratory tract swabs is a good choice. Consecutively sampling at this time as close symptom onset as possible will be better. The antibody testing not for early diagnosis of the COVID-19. So then at the end, I would like to thank Sichuan Provincial Health Commission for providing the data for our study. And I really appreciate our hospital and department for supporting the study, and have many thanks to my colleagues for hard work to fight the virus with me together. Thank you so much for your attention.
Thank you, Dr. Li Jiang, for your informative presentation. As a reminder, our speaker will follow up with any questions you have submitted via email following this webinar. We would also like to thank LabRoots for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period, will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand through the end of this year, 2020. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.